Hi, my name is Candace Benner. I am a family nurse practitioner who has subspecialized in ears, nose, and throat for the last 14 years. You are getting ready to view the first of 5 modules that I have created to help nurse practitioners and physician's assistants evaluate and treat common ears, nose, and throat complaints. Upon completion of this module, the clinician will be able to evaluate for the various forms of hearing loss, develop an appropriate treatment plan based on the diagnosis, evaluate outcomes of treatment utilized, and lastly, identify outcomes that need further evaluation and why. Hearing loss does not discriminate. It can be observed in all ages, races, and in sexes, as well as within all geographic locations and socioeconomic levels. Hearing loss can be classified as congenital or acquired and can be further subdivided into types of hearing loss such as conductive, sensorineural, mixed, or central. A common impairment, especially observed in the aging population, is hearing loss. The hearing loss itself can occur from problems in the outer ear, middle ear, or inner ear. A conductive hearing loss can be due to external ear conditions that block the transmission of sound to the middle ear. The potential structures that can be involved in a conductive hearing loss can encompass the external ear canal, tympanic membrane, or the middle ear space. As you can see from the table, cerumen impaction or a foreign body can obviously create a conductive hearing loss. These simply need to be debrided under binocular microscopy. In addition, otitis externa, otomycosis, and dermatitis can also cause a conductive hearing loss, and these again need to be debrided under binocular microscopy and treated appropriately with antibiotic or with or without steroids, or as well as an antifungal agent. The next 3 slides will walk you through how to evaluate and treat a potential conductive hearing loss that is in the middle ear space. The patient will present sometimes with complaints of hearing loss. Upon physical exam, no abnormalities are identified. The tuning fork may suggest a conductive hearing loss as well as audiogram results. One should consider otosclerosis or possibly even a semicircular canal dehiscence. To confirm a semicircular canal dehiscence, you would need to obtain a CT of the temporal bone and a VEM. However, in order to confirm otosclerosis, surgical exploration needs to be considered. Again, this would be a referral to the surgeon. I would like to point out on this slide that those clinicians that have the ability to perform a nasal endoscopy, should they find a nasopharyngeal mass, will need to make an immediate referral to the ears, nose, and throat surgeon. Should the clinician find no abnormalities upon nasopharyngeal exam, and the patient has an acute serous otitis media, treatment options could include a nasal steroid spray, as well as positive pressure exercises and watchful waiting. Should the patient have a chronic serous otitis media or a chronic otitis media, after 2 to 3 months of unimproved symptoms, the patient should again be referred to the ears, nose, and throat surgeon. When a patient presents to the office with complaints of hearing loss, it is up to the clinician to determine if the hearing loss was sudden. This slide looks busy, but with appropriate questioning, it should lead the clinician to the appropriate diagnostic reason for the hearing loss. I would like to point out with Meniere's disease, it is a diagnosis of exclusion. The patient would need to have the following constellation of symptoms, including dizziness, which is usually described as vertigo, fullness in the affected ear, tinnitus, which is sometimes described as a roar, and fluctuation of hearing in the affected ear. In order to diagnose the patient with Meniere's, VNG and ECOG may be found useful in obtaining test results that would lend the clinician to believe, or at least support, the diagnosis of Meniere's disease. An MRI should also be obtained to rule out space-occupying lesion, as well as the possibility of an acoustic neuroma on the 8th cranial nerve. Clinical practice guidelines developed by the Academy of Otolaryngology head and neck surgeons strongly recommend treatment of a sudden hearing loss within 4 weeks of the initial drop in hearing. The initial treatment includes oral prednisone, 60 milligrams for 14 days without a taper. The second option, should the patient not be able to tolerate the oral prednisone, would include intratympanic membrane injections of dexamethasone, and this is usually done in a series of 3, but not necessarily all 3 injections would be completed. This, of course, would require referral back to the ears, nose, and throat surgeon.